Hello, my name is Dr. Kimberly Cheatham. Welcome to a video presentation on amenorrhea. The objectives for this presentation are listed here. Amenorrhea is the absence of menses and can be categorized as primary or secondary. Primary amenorrhea is defined as either no menses by age 14 years in a female with no growth spurt and no secondary sexual characteristics, or no menses by age 16 years in a female with evidence of a growth spurt and the presence of secondary sexual characteristics. Secondary amenorrhea is the absence of menses after 3 to 6 months in a woman who has previously menstruated. What are secondary sexual characteristics? These are breast development and pubic hair growth. When a female has breast development, this is a sign of previous estrogen exposure, estrogen made from the ovary. Pubic hair signifies the production of androgens by the adrenal gland and functional androgen receptors. If a female has never menstruated but has breast development, you can conclude that her ovaries are at least making estrogen. Normal menstrual function requires that the brain, ovaries, and uterus are functioning appropriately and that the outflow tract of the uterus, cervix, and vagina is patent. If there is an abnormality at any of these levels, amenorrhea may occur. We will focus on secondary amenorrhea because this is the most likely presentation a PA will see. A differential diagnosis for secondary amenorrhea is listed here. As you evaluate the amenorrheic patient, you should inquire about signs or symptoms related to these conditions. Questions to ask during the history would include topics listed on this slide. The physical examination should also evaluate for signs that would point to a cause of secondary amenorrhea. In addition to the history and physical exam, laboratory testing can be helpful in making the diagnosis for a patient with secondary amenorrhea. Pregnancy is the most common cause, so a pregnancy test should always be performed. Thyroid disease and hyperprolactinemia are also common and can be evaluated for with a TSH and a prolactin level. The gonadotropins FSH and LH can indicate whether ovarian failure is present by being elevated, or that hypothalamic suppression may be present if the gonadotropins are very low. Estradiol levels can also evaluate ovarian function. If the pregnancy test is negative and a TSH, prolactin, FSH, LH, and estradiol are normal, the patient most likely has anovulation. This can be confirmed with a progestational challenge test. If a patient is anovulatory, her ovaries are usually making plenty of estrogen. But since an egg is not released, a corpus luteum never forms, so progesterone is not made. This can lead to amenorrhea. If a progestin is supplied to the patient for a week, it replaces the progesterone that would have been made after ovulation. Withdrawal of progesterone is what elicits a normal menstrual bleed, so stopping the progestin medication after a week should lead to a menstrual period. Bleeding after a progestational challenge confirms the presence of anovulation. Once you identify the cause of secondary amenorrhea, you can consider appropriate treatment. Treatment is based on the etiology. If anovulation is present with normal estrogen levels, the patient is at risk for endometrial cancer, so a progestin will need to be given to the patient. If anovulation is present with low estrogen levels, as occurs with hypothalamic suppression, the patient is at risk for bone loss and future osteoporotic fractures. This patient needs supplemental estrogen and progestin. This is the end of the presentation on amenorrhea.